Let's talk about amblyopia, commonly known as lazy eye. There's a couple of different conditions that can lead to amblyopia. One of the most obvious that we know about is when we see an eye that wanders in or out. And so when we have an eye that is in or out and not coordinating with the other, what ends up happening is that we're getting one picture coming from the right eye to the brain and one picture coming from the left eye to the brain, but the pictures don't line up. And so the brain will often do what's called a suppression. It will just filter out or ignore the information that comes from that eye. And over time, when the brain does that, it leads to the situation where now that eye isn't correctable to 20/20 like the other one. And that's what's called amblyopia. Another way that that can develop is if we have significant amount of prescription in both eyes or a significant difference in prescription between the two eyes. And this is a little bit trickier to pick up, especially when they're younger, because if they have one eye that's seeing really well on the eye chart or day in and day out, then parents don't notice their child doing the obvious things like squinting or complaining that things look blurry. And what's happening is the brain's getting one clear image and the brain's getting one blurry image. And so again, the brain suppresses or ignores the information that's coming from the eye with all the prescription. And over time, that can lead to amblyopia, where now the eye isn't correctable to 20/20. In those cases, the good news is that vision therapy can help tremendously. So the number one step is to make sure that we have the most appropriate prescription. So the best prescription we can to correct the refractive error and to help with alignment of the eyes. And then the second part of that would be to work therapeutically with that patient to help them achieve the ability to coordinate the eyes together, for the brain to be able to use the eyes together and not suppress or ignore the image that's coming from the other one. A long time ago, the thought used to be that patching was the most effective thing that we could do for patients with amblyopia. And the idea behind patching is that I'm going to cover the better seeing eye and I'm going to force the brain to pay attention to the weaker or lesser eye. And then what we're going to hope is that when we take the patch off, now the brain uses both eyes together and quits suppressing or ignoring. In some cases, we would find that that worked, but in a lot of cases, it didn't. And so now what we look at from a therapy perspective is a way to have a couple of stepping stones between monocular vision, where my brain is using only one eye at a time, to binocular vision, where my brain's able to use both eyes together. And this is much, much more effective than just patching alone. There was a thought process years ago that neuroplasticity ended at 8 years old. And sometimes we still hear patients told that once they've exceeded the 8-year-old mark, there's nothing that can be done to treat their condition. What we know is that neuroplasticity lasts well into adulthood. And so in those cases, that means that we can actually still treat amblyopia successfully in older children, in teenagers, and even into adulthood.
Is it as effective with adults?
The percentage of effectiveness is less in adult population than it would be in a younger child. However, it doesn't mean that we can't gain benefit and improvement in their overall function. So sometimes with adults, it's more centered around not trying to make your eye 20/20, but trying to give you peripheral depth perception, the ability to be more aware of where you are when you're driving your car. So you're more comfortable with the cars around you, more comfortable with when you're stopping and things like that. So not always just focused on what your acuity is on the chart, but more day in and day out function and what you need.